So advantages of non-invasive ventilation: ease of use, reduced for skilled caregivers, obviously elimination of the trach, improved comfort, allows improved speech. Like I'll tell my patients with mouthpiece ventilation, use it if you know you're going to be on the phone. Use it if you know you're going to have visitors. Because what do we need in order to talk nice and loud? We need to take a nice big breath in. If you can't take a big breath in, you're not going to get that voice out. So use this non-invasive aspect to get that breath and talk really loud. One of my favorite things to do with my patients in the home settings, my patients that have little kids, I'll holler, hey, you miss yelling at your child? Get that mask on, take a couple of big breaths, and all of a sudden you can start yelling at your kids again. It works. And of course, lower overall cost of care. If someone gets sent home with a tracheostomy tube, we now have increased caregiver needs. We have to have 24/7 caregivers. Plus, of course, with the trach, we have increased risk of infection, increased mucus production, because that's your body's automatic response to that weird thing in the neck. So everything just kind of goes towards NIV has much more advantages than invasive. With our patients with chronic respiratory insufficiency, when do we initiate that non-invasive ventilation? The sooner we get a patient on a BiPAP or VPAP at night, the better, okay? Treating nocturnal hypoventilation before they become short of breath during the day is going to improve that during the day breathing. If you have someone that's hypoventilating all night long, dropping their saturation, increasing their CO2s, what do you think is going to happen the whole next day? Their body's trying to compensate for that drop throughout the whole night. So they're working harder the next day. Let's get them on a mask at night while they're sleeping so they don't have to make up for that during the daytime. All right, Ileane already mentioned that muscle weakness. It makes it more difficult to push out the CO2, causing the CO2 retention, of course, possibly putting your patient into respiratory failure. So we already talked about your signs and symptoms, that increase in CO2. This is one of the things when I'm in a patient's home too, I just need the families on, things to watch for. Of course, you have your morning headaches, your sleepiness, it's difficult to wake up. You know, if you have a patient that's really up there on the CO2s, they're doing the sleepy thing, and you can kind of get them to open their eyes, but then they go right back again. That's my first indication. We need to kind of think that maybe their CO2 is too high, and what is the thing we're going to do to try to decrease the CO2? Anyone? What do we want to do to decrease the CO2? Increase the BiPAP. Get them on that mask, okay? Mask, mask, mask. You cannot be on your mask too much.
Just wanted to interrupt a second. The signs of the yawning is very prevalent in this disease, and in the morning especially, and that's your first signal, can be your first signal that they wake up with the headache and the yawning. Their pressures might need to be changed on their NIPPV, on their BiPAP, their trilogy.
Okay. All right, so there's our goals. All right, so this, again, you're going to go a little bit deeper when you get your handouts from my presentation, but I want to, real quick, so many choices. You guys have heard all of these things before, okay? CPAP. CPAP is contraindicated in our neuromuscular patients, okay? CPAP is continuous positive airway pressure. That is specifically upper airway obstruction, sleep apnea, okay? You do not want to put a neuromuscular patient on a CPAP. It's not going to help them at all. You will hear me and other respiratory therapists and other nurses, and you may have heard already the term BiPAP, and then you may have heard the term VPAP, okay? Just so you guys know, it's the same, all right? BiPAP stands for bi-level positive airway pressure. You have one pressure for that breath in, and then one pressure, keep the airway open for that breath out, okay? Respironics, a brand name, trademarks the term BiPAP. So another brand name, ResMed, can't call it that, okay? So they call it VPAP, which just stands for variable positive airway pressure. Exact same thing, okay? Again, you just have that one set pressure in, one set pressure out. With a BiPAP, again, it's only one pressure. So the patient's tidal volume is going to fluctuate, okay? If the patient's sitting up, feeling a little bit stronger, they may hit that inspiratory pressure and get a pretty decent tidal volume in. But it's nighttime, they're tired, they're kind of lying down now. It's only going to hit that pressure, but their tidal volume may drop in half, okay? So that's a BiPAP, just one pressure in, one pressure out. So, and what a BiPAP is basically used for your COPD patients, okay? What what we're going to do with our ALS patients is put them on what's called a BiPAP ST. Okay. Now, all of these breathing devices that I'm talking about today are all spontaneous breathing. Okay. Nothing is going to breathe for our patients. Nothing is going to force them to breathe. Okay. What these do is these assist in their own spontaneous breath. So a patient has to trigger that machine to get that breath in. Once the machine feels them trigger, it's going to kind of just give them a boost to their own volume, again, increasing their tidal volume so that we can get rid of the carbon dioxide. Now, what the ST means in this is we have what's called a backup rate spec. Now, the backup rate, again, it's not going to ventilate your patient, but all that does is, and these are all the settings are ordered by the physician. All your backup rate does is if your patient, especially in that nice deep sleep stage, okay, if they happen to drop their respiratory rate below that backup rate, the machine is just going to trigger from its expiratory phase. It's going to kind of just trigger over to the inspiratory phase. And the way I like to explain it, it's kind of like giving the airway a little funk. Kind of like, hey, you should take a breath in, okay? Now, I have explained to my patients' families as well, too. Again, even though it's doing these things where it might trigger from expiratory to inspiratory, if your patient isn't going to start breathing, this machine's going to try to trigger again. But if they've passed, it's going to just keep trying to trigger and nothing's going to happen. Okay? I explained to all my family members, I have had patients that have passed away with their mask on because, again, we're not forcing them to breathe. We're just assisting their spontaneous breath. Okay? Again, the settings will be done by the pulmonologist. One of the other things you guys may see, this is a little bit of a higher step above that BiPAP with that backup rate. There's a couple of new things out there. One is called BiPAP AVAP. AVAP is a respironics term. Again, here we go with these terms. The big difference with AVAP is now we have a set guaranteed tidal volume. So it's kind of neat. So instead of getting that one pressure in and then dropping down out and having your tidal volume be variable, we have a set guaranteed volume. So let's say I want my patient to have at least a tidal volume of 500 milliliters, okay? What it's going to do is instead of one set inspiratory pressure, we're going to give that inspiratory pressure a window, okay? So let's say that patient is sitting upright, feeling nice and good. She doesn't really need a lot of help. That little window of the inspiratory pressure is going to start here. But they fall asleep, their volume starts decreasing down, she's not hitting that 500 milliliters. That support, it's called pressure support, is going to increase. It's like a smart machine. It's going to increase, helping that patient get that volume that we want them to get. The next one, again, is called VPAP IVAPs. Okay? Again, we have Respironics versus ResMed. Okay? They both pretty much do the same thing. It's kind of like comparing a red apple with a green apple. All right? Your AVAP is a set tidal volume. ResMed try to be a little bit fancier. They're calculating that volume based on not calculating in anatomical dead space. Again, these are things that the physician would decide on an order ahead of time. So we have our BiPAP machines. Your regular basic BiPAP, VPAP, ST machines are just that. It's just a simple machine. It's plugged in. It works while it's plugged in. You're good to go. The negative aspect of these machines is there's no portability. And I don't want to say there's no battery backup, but there's not great battery backup. Now, a patient can purchase a backup battery for these units. They're about $300. You can find them online. But you have to have everything all ready. If power goes out, you have to quickly disconnect one, reconnect the battery, and your battery life is only going to be about 4 hours if you're lucky. Okay? If we have a patient who needs to be on their non-invasive ventilation for more than 13 hours, okay, or if you have a patient that really cannot come off their mask for more than half an hour at a time, that's when you want to start looking and thinking about the Trilogy and the Astral. Okay, so basically what these are, technically they are coded as ventilators. They can be used invasively, but the benefit of these is portability, backup battery. This is a vent. Isn't that cute? Remember those days we pushed them in the hospitals? Okay, so this is a vent. This is the Astral. So this machine has battery capability of 8 to 12 hours. And if we really needed to, there's also external batteries that you can piggyback to have someone go with 24 hours on this. Okay? The other device is called a Trilogy. It's a little bit heavier. This is 7 pounds. Your Trilogy is 11 pounds. Battery backup on the Trilogy is about 6 hours. And again, to decide which one to go would be whether or not the doctor wants that IVAS, Astral, or AVAS, Trilogy.
To make sure they understand, we are not using this as a ventilator.
Yeah, it is, exactly. It's not being used as a ventilator, even though the machine is, like I said, coded. We are still using it on our spontaneous mode. We're still putting it on your VPAP type settings. Just the purpose of it is for that battery backup. The other benefit of an Astral or Trilogy is that sip and puff ventilation, because you can't do that on a regular BiPAP. Okay? You have to have an Astral or a Trilogy if the patient wants or needs that sip and puff capability during the day. Talks about the Trilogy, talks about the Astral. Sip and puff, as I said, that's just if they want a breath, they just trigger in that breath in. It's going to give a little boost. One way I've explained it to patients, and they really kind of understood, this inspiratory pressure that we give to deliver volume, okay, it's kind of like we're standing in front of a fan on low, okay, and if someone was to turn that fan on super high, even you just breathing, you're going to feel that little extra boost of breathing, right? That's basically what we're doing. We're turning their fan from low to higher, just assisting their own spontaneous breathing. Another benefit of the sip and puff ventilation is we can use that for breath stacking. Have any of you done breath stacking with a patient? Okay, there's a presentation on that you can get as well. Do any of you know what breath stacking is? You could probably guess. Pretty much goes along with the actual term of it. Okay, breath stacking you can do with your Astral Trilogy, or what we usually do ahead of time. This is one of the first therapies we provide our patients, is done with an ambu bag. Okay, have you all worked with an ambu bag before? All right, so you know your ambu bag, you have your basic inspiratory, expiratory, you squeeze, breath goes into the patient, you let go, breath comes out, right? So with breath stacking, what we do is we add a one-way valve to it, okay? So then your patient is going to stack one breath on top of another to really hyper-expand the lungs, okay? As we talked about, one of the things is that low muscle tone in the diaphragm, so we're really not breathing that deep. Our patients are not opening up the lower areas of the lungs, which is going to increase the risk of pneumonia, okay? So with breath stacking, we do breath, 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 literally stacking one breath on top of the other, and then just let them exhale. Breath stacking is good to use just for shortness of breath. It's good to use for exercise. Again, this is one of the first therapies the clinic will send home with the patient. I tell my patients, bring this with you, especially if they don't have the Trilogies and the Astral. If your patient is going out during the day and they don't have anything to help them if they become short of breath during the day, get your breath stacker. You don't need plugs, you don't need anything, you're short of breath, just give yourself a couple of breaths in, and you're good to go with that. So it is nice and easy, convenient, and portable. Thank you.